Hello, I'm Ruth Stewart. I'm the National Rural Health Commissioner, and I've been asked to talk to you today about rural health care. I'm going to share with you a presentation that I've prepared. Just bear with me while I bring that up on the screen. Let's hope this works. There we go. So I'm joining you at your 50th annual ICPA conference, Stronger Together. I'd like to begin by acknowledging the traditional custodians of the land on which we each sit. I am on Mandindangi land, and I acknowledge the elders past, present, and emerging of all of these nations. I pay my respects to the elders of these nations, and I extend that respect to all Aboriginal and Torres Strait Islander people who are here with us today. You are most welcome. So, who am I? I've been 30 years a rural generalist doctor. I'm a GP obstetrician. So I've lived in rural communities all my life, apart from that time when I had to go to Melbourne to be educated as a doctor. And I've provided cradle-to-grave care. At 12 years in rural medical education at Deakin University and also at James Cook University. And I've been the president of the Australian College of Rural and Remote Medicine between 2016 and 2018. Also been a board member of the Torres and Cape Hospital and Health Service from 2012 to 2020. I just stopped that job and the university roles to take on this one. So what is this role? I am called on to consult with rural, regional and remote stakeholders and communities to formulate advice for Minister David Gillespie, who you can see there. I'll just move my picture away from him, his face there. And so that advice from me is to assist Minister Gillespie to develop rural health strategy and policy. Now, what is my office? So this photo here shows both Minister Hunt to my left in the picture and the former Minister for Regional Health, Minister Mark Coulton, to my right. It also shows my deputy commissioners. The office is an independent statutory office. That means it was created by an Act of Parliament. And that legislation lasts for 5 years. My role, been given a 2-year contract, which could possibly be extended if I behave myself. I have these 2 deputy commissioners who you can see standing either side of the ministers there. On the right is Adjunct Professor Faye McMillan, and on the left is Adjunct Professor Shelley Nolan. Shelley Nolan has expertise in nursing and Faye McMillan has expertise in allied health. She was the first Aboriginal pharmacist in Australia. And in the office we have 4 policy advisors and 2 administrators. What are the priorities of the office? I am to implement the Rural Generalist pathways in allied health and medicine, to report to the Minister on the impact of COVID-19 on rural health workforce, to work with the Department of Health on the implementation of the recommendations from a recent evaluation of the Rural Health Multidisciplinary Training Program. That's the program that has been going for 25 years, putting training sites for the universities, colleges of medicine and dentistry and allied health training in rural and remote communities. I have to assist the department in the transition of general practice training from the department to the general practice colleges, And I'm called upon to create grant opportunities for innovative models of care. Now, how do we support the health needs of geographically isolated children? A couple of ways we do this: by promoting rural generalism for health professionals. If we have rural generalism, where both the health professionals are trained to have the broader scope of practice and are trained in rural communities, they're much more likely to be skilled and confident and competent to return to rural communities. So my role is to advocate for innovative multidisciplinary models of care to encourage better care coordination so that those healthcare professionals who are in rural and remote communities are enabled to work closely together to provide better coordinated care. Sounds obvious, doesn't it? But you'd all know that it doesn't always happen. And I'm also advocating for appropriate funding to support these sustainable multidisciplinary primary healthcare teams. At the moment, health funding flows where there are doctors and where there are hospitals, and it isn't directed at primary healthcare teams. It's primary healthcare teams that actually keep a community healthy and well. So that's what we need in rural and remote communities. And it's lack of access to such teams that is actually having a large impact on health outcomes for rural people. So these rural generalists, what are they? They're connected to the community, personally and professionally, so they live in the rural communities. But most especially, they have the broadest scope of practice. So they're not narrowing down on a subspecialty field. They treat what walks in the door. They know what their limits are and they know when to refer, but they try and keep as much of your care as close to home as possible, whilst keeping that care high quality and safe for you and your family and community. So they need to be flexible and adaptive, tailoring their service provision for the needs of the community. And most especially, they need to work together in a multidisciplinary team. I can't do everything as a GP, but when I have a multidisciplinary team around me, we can coordinate the care that you need as a rural or remote resident. I've mentioned innovative models of care. That means doing things differently. Now, you can see this picture of a gate, farm gate, way out the back of Thornborough on the western edge of the Atherton Tableland. Some of you might know where I'm talking about. It's one of my favourite mountain bike rides. Anyway, why am I showing you a picture of a farm gate? Because I think that models of care for rural and remote should be like the farm gate, using what you've got available to solve the problem that you've got where you are. You've got a hole in the fence that's a certain width. You need to be able to open it and close it reliably, and you need to just use what's available. We sometimes call that a strength-based approach. It's also place-based, and you need to integrate your primary care, and it needs to be multidisciplinary. If you just focus on the skills of one discipline, one health professional discipline, there won't be enough services for the community needs. That care needs to be culturally responsive and safe so that people are happy and comfortable to use the service that's provided. And it needs to address the local health needs, not the ones that people off in the city think are your health needs, but the ones that you know are your needs in your community. So it also needs to address local service and workforce needs. So what are the things that you don't have in your community, and how are we going to fix that lack? Multidisciplinary care and coordination can operate with schools and outreach clinics, hospitals, medical practitioners, allied health professionals, nurses, health workers, and health practitioners. And it can be supported by telehealth. I'm sure everybody here is aware of the work of the RFDS. The RFDS, Royal Flying Doctor Service, has been providing telehealth since they began. It used to be called radio health. Yeah. So we're stronger together. It's not about what we don't have, it's about what we do have and what we can do with what we have. Thank you. Okay, bye.